Your doctor tells you your blood pressure is 138/82 and says you need medication. Your neighbor is 74 years old, has a blood pressure of 145/88, feels perfectly fine, and her doctor says she is doing great. Another friend your age has a reading of 118/72 and was told that is dangerously low for someone his age. How can all three of these things be true at the same time? The answer lies in one of the most misunderstood and genuinely controversial areas of medicine: what blood pressure numbers actually mean after the age of 60, 70, and beyond. Stay with me, because what you are about to learn may completely change how you think about your own heart health, and it could save your life. Welcome back to Healthy Living After 50. I'm Dr. Michael Kent, and today we are diving deep into one of the most important and most frequently misunderstood topics in senior health: blood pressure. Specifically, we are going to answer the question that millions of older adults are asking their doctors and not getting a fully satisfying answer to: what is actually the right blood pressure number for someone my age? Now, I want to be upfront with you from the very beginning. This is not a simple topic. The answer is not one clean number that applies to every person over 60 or 70 or 80. The answer depends on your age, your overall health picture, the medications you take, whether you have conditions like diabetes or kidney disease, your history of falls, and several other deeply individual factors. What I am going to give you today is the real, full picture. The kind of information that used to live only in medical journals and specialist consulting rooms, so that you can have a genuinely informed conversation with your own doctor and make the best decisions for your own health. We are going to cover what blood pressure numbers actually mean and why they matter, how the guidelines have changed, and why those changes are still debated among cardiologists today, what the real risks of blood pressure that is too high look like in older adults, what the equally real and often ignored risks of blood pressure that is too low look like in older adults, the natural lifestyle strategies that have the strongest evidence behind them, and when medication makes sense, and when it might actually cause more harm than good. This is a thorough video because this is a topic that deserves thoroughness. Get comfortable, because by the end of this, you will know more about your blood pressure than most people ever do. What blood pressure numbers actually mean. Let's start at the very beginning, because even people who have been monitoring their blood pressure for decades sometimes do not fully understand what those two numbers are actually measuring. When your blood pressure is recorded as, say, 130/80, you are looking at two distinct measurements that together tell a story about how hard your heart is working and the condition of your blood vessels. The top number, the systolic pressure, is the pressure inside your arteries at the moment your heart contracts and pushes blood out into your body. The bottom number, the diastolic pressure, is the pressure inside your arteries in the brief moment between heartbeats, when your heart is relaxed and refilling with blood. Both numbers matter, but they matter in different ways and to different degrees depending on your age. In younger adults, elevated diastolic pressure, that bottom number, tends to be the bigger concern. But as people age into their 60s, 70s, and beyond, the systolic number, that top reading, becomes far more clinically significant. This is because, as we age, our arteries naturally become stiffer and less elastic. This arterial stiffening is a normal part of aging, but it causes the systolic pressure to rise even when the heart itself is working normally. It also leads to what is called a wider pulse pressure, the gap between the top and bottom numbers. A wide pulse pressure in an older adult, where the systolic is high but the diastolic is relatively low, is actually considered a marker of arterial aging and cardiovascular risk in its own right. Understanding this is essential because it changes the way we think about what a good blood pressure reading looks like at 45 versus at 75. How the guidelines have changed, and why the debate continues. For many decades, the medical world operated on a very simple rule when it came to blood pressure. 120/80 was the ideal. Anything above 140/90 was hypertension requiring treatment, And the goal of treatment was to get everyone's numbers as close to 120/80 as possible, regardless of age. This was the standard. It was taught in medical schools, printed in guidelines, and applied across the board to patients of all ages. And for younger and middle-aged adults, it was largely sound advice. But then the research started getting more complicated. Scientists noticed something unexpected. When they studied populations of older adults, particularly those in their late 70s and 80s, they found that the people with the very lowest blood pressure readings were not necessarily the healthiest or the longest lived. In fact, in multiple large studies, older adults who had their blood pressure pushed down very aggressively with medication had higher rates of falls, kidney problems, dangerous drops in blood pressure upon standing, and in some cases, higher rates of death than those whose blood pressure was managed less aggressively. This was genuinely alarming to the medical community, and it prompted a significant rethinking of how blood pressure guidelines should apply to older patients. In 2017, the American Heart Association and the American College of Cardiology released updated guidelines that lowered the threshold for hypertension from 140/90 to 130/80. Under these new guidelines, a far larger percentage of the adult population, including many older adults, was suddenly classified as having hypertension. These guidelines were based on the findings of a landmark study called the SPRINT trial, which found significant benefits to targeting a systolic blood pressure below 120 in high-risk patients. But here is the critical detail that is often left out of the headline. The SPRINT trial specifically excluded patients with diabetes, prior stroke, and dementia, and it used a very specific method of measuring blood pressure: automated, unattended measurement in a quiet clinical setting that tends to produce lower readings than the standard measurement most people receive in a doctor's office. This means the 120 systolic target from SPRINT may not translate cleanly to the real-world population of older adults sitting in their family doctor's waiting room. Many cardiologists and geriatricians, doctors who specialize specifically in the care of older adults, continue to advocate for a more individualized approach. The European Society of Cardiology guidelines, for example, recommend a target systolic blood pressure of 130 to 139 for adults aged 65 to 79, and suggest that for adults aged 80 and older, a systolic between 130 and 139 is still a reasonable target provided it is well tolerated, meaning the patient does not experience symptoms of low blood pressure like dizziness, fatigue, or falls. The key phrase in all of these recommendations is individualized care. There is no single number that is right for every older adult. There is a range, and where within that range you should aim depends entirely on your own health picture. The real risks of blood pressure that is too high in older adults. Let's be absolutely clear. Persistently elevated blood pressure in older adults is a serious health concern and should never be dismissed or ignored. High blood pressure, or hypertension, is often called the silent killer precisely because it produces no obvious symptoms in most people, even when it is doing significant damage to the body over months and years. The damage it causes is progressive, cumulative, and affects multiple organ systems simultaneously. At the cardiovascular level, sustained high blood pressure forces the heart to work harder with every single beat, year after year. Over time, this causes the walls of the heart muscle to thicken, a condition called left ventricular hypertrophy, which paradoxically makes the heart less efficient and more prone to dangerous rhythm disturbances. It accelerates the development of atherosclerosis, the buildup of plaque inside arterial walls, which narrows the arteries and dramatically raises the risk of heart attack and stroke. High blood pressure is the single most significant modifiable risk factor for stroke in the world. A stroke in an older adult is not just a medical emergency, it is often a permanent, life-altering event that strips away independence, cognitive function, and quality of life in ways that are devastating for the individual and for their family. At the brain level, chronic hypertension damages the tiny blood vessels that supply the brain with oxygen and nutrients. This damage accumulates silently over years, and research has now firmly established that sustained high blood pressure in midlife and early older adulthood is a major risk factor for vascular dementia, the second most common form of dementia after Alzheimer's disease, as well as for accelerated cognitive decline more broadly. White matter lesions, areas of damage in the brain's connective tissue, are seen far more frequently on brain scans of older adults with uncontrolled hypertension than in those with well-managed blood pressure. The brain you have at 80 is significantly shaped by the blood pressure you had at 55, 60, and 65. At the kidney level, high blood pressure damages the delicate filtering units of the kidney, the nephrons, and this damage creates a vicious cycle, because damaged kidneys then become less efficient at regulating blood pressure, which causes blood pressure to rise further. Hypertensive kidney disease is one of the leading causes of chronic kidney failure in older adults, and declining kidney function in turn affects the safety and dosing of virtually every medication an older person takes. The heart, the brain, the kidneys, high blood pressure is attacking all of them quietly and simultaneously. This is why taking it seriously and managing it thoughtfully is so important. The equally real, and often ignored, risks of blood pressure that is too low. Now here is the part of the blood pressure conversation that does not get nearly enough attention, and for older adults, it may be just as important as the risks of high blood pressure. Blood pressure that is too low, or blood pressure that is driven too low by aggressive medication treatment, carries its own serious and sometimes life-threatening risks for people in their 60s, 70s, and 80s. The most immediate and visible risk is falls. When blood pressure is too low, the brain does not receive adequate blood flow, and this causes dizziness, lightheadedness, and unsteadiness, particularly when a person stands up quickly from a sitting or lying position. This phenomenon is called orthostatic hypotension, and it is extremely common in older adults, particularly those on blood pressure medications. A fall in an older adult is not a minor inconvenience. Falls are the leading cause of injury-related death in adults over 65 in the United States. A hip fracture resulting from a fall has a 1-year mortality rate of 15 to 30% in older adults, meaning that somewhere between 1 in 7 and nearly 1 in 3 older adults who break a hip will not be alive 1 year later. And this risk is directly linked in multiple studies to blood pressure medications that push systolic pressure below 120 in elderly patients who are already at fall risk. Beyond falls, persistently low blood pressure in older adults reduces blood flow to the brain, which can accelerate cognitive decline and increase the risk of dementia, the very same outcome that high blood pressure causes through a different mechanism. A landmark study published in JAMA Internal Medicine found that in adults over 80, low diastolic blood pressure, that bottom number below 60 or 65, was associated with significantly increased rates of cognitive decline and dementia, independent of other risk factors. This finding has led many geriatricians to argue that in the oldest old, adults over 80, the obsession with lowering blood pressure numbers must be tempered by a careful assessment of the risks of going too low. There is also the issue of kidney perfusion. The kidneys require adequate blood pressure to filter blood effectively. When blood pressure drops too low, particularly in older adults who already have some degree of age-related kidney decline, the kidneys can be significantly stressed, a condition called renal hypoperfusion, which can trigger acute kidney injury and accelerate chronic kidney disease. Many older adults on aggressive blood pressure treatment regimens develop worsening kidney function that their doctors attribute to kidney disease, when in reality the medications themselves are part of the problem. The message here is not that blood pressure treatment is dangerous and should be avoided. The message is that treatment must be calibrated, carefully, individually, and with full awareness of both the risks of going too high and the risks of going too low. And this calibration requires a doctor who knows you as a whole person, not just as a set of numbers on a chart. What is actually a reasonable blood pressure target for you? Given everything we have covered, let's try to bring this to a practical, personalized framework. For adults between the ages of 60 and 70 who are otherwise relatively healthy, no diabetes, no chronic kidney disease, no history of stroke, no significant fall risk, most current evidence supports aiming for a systolic blood pressure in the range of 125 to 135. Getting below 130 is generally beneficial for this age group if it can be achieved comfortably without side effects. The diastolic pressure should ideally remain above 70. A diastolic that drops below 65 in this age group begins to raise concerns about coronary artery perfusion, meaning the heart's own blood supply may be compromised. For adults between the ages of 70 and 79, the picture becomes more nuanced. A systolic target of 130 to 140 is generally considered appropriate, with the lower end of that range being preferable if the patient tolerates it well and has no significant fall risk, orthostatic hypotension, or kidney concerns. The key phrase is tolerates it well. If achieving a systolic of 130 requires 3 blood pressure medications and causes the patient to feel dizzy every time they stand up, the treatment itself is creating more risk than the slightly higher blood pressure would have. In this age group, quality of life and safety must be factored into the target alongside the raw numbers. For adults aged 80 and older, the consensus among geriatric medicine specialists has shifted meaningfully in recent years. Most geriatricians now agree that a systolic target of 140 to 150 is appropriate for the majority of adults in this age group, and that attempting to push systolic pressure below 130 in an 80-year-old carries real risks of falls, kidney injury, cognitive worsening, and reduced quality of life that often outweigh the cardiovascular benefits. The body of a healthy 80-year-old has adapted to a slightly higher blood pressure over decades, and abruptly normalizing it with aggressive medication can destabilize systems that have found their own equilibrium. There are, of course, exceptions and individual variations to all of these general frameworks, and this is precisely why the conversation with your doctor matters so much. What I want you to take away from this section is that the right blood pressure for you is not simply whatever number a guideline says. It is the number that balances cardiovascular protection with the safety of your kidneys, your brain, your ability to stand up without falling, and your overall quality of daily life. That balance is individual. It requires an individualized conversation. The natural lifestyle strategies with the strongest evidence. Regardless of whether medication is part of your blood pressure management, lifestyle interventions have powerful and well-documented effects on blood pressure in older adults, and they come without the side effect profiles that medications carry. Let me walk you through the ones with the strongest evidence base. The single most impactful lifestyle change for blood pressure reduction is reducing dietary sodium. The evidence here is overwhelming and consistent across decades of research. The average adult in the Western world consumes between 3,400 and 4,000 milligrams of sodium per day. Current guidelines recommend staying below 2,300 milligrams per day for most adults, and the evidence suggests that reducing sodium intake to around 1,500 milligrams per day can lower systolic blood pressure by 5 to 10 points in salt-sensitive individuals, an effect comparable to a low-dose blood pressure medication. Critically, older adults tend to be more salt-sensitive than younger people, meaning the blood pressure response to dietary sodium is more pronounced. The vast majority of dietary sodium does not come from the salt shaker on your table. It comes from processed foods, packaged foods, restaurant meals, canned soups, deli meats, and bread. Reading labels and choosing lower sodium options is where the real impact is. The second strategy with exceptional evidence is the DASH diet, dietary approaches to stop hypertension. The DASH diet emphasizes vegetables, fruits, whole grains, lean proteins, and low-fat dairy, while minimizing red meat, saturated fat, and added sugar. Multiple randomized controlled trials, the gold standard of medical evidence, have demonstrated that following the DASH diet can reduce systolic blood pressure by 8 to 14 points. For context, that is a greater reduction than many single blood pressure medications achieve. The DASH diet is not a weight loss diet, although weight loss often follows naturally. It is a nutritional strategy specifically designed around what the cardiovascular research shows about how food affects arterial health and blood pressure regulation. The third strategy is regular aerobic exercise. This does not mean training like an athlete. It means consistent, moderate-intensity movement on most days of the week. Walking, swimming, cycling, dancing, water aerobics. Research shows that consistent aerobic exercise lowers resting systolic blood pressure by 4 to 9 points on average in older adults with hypertension. More importantly, exercise improves arterial elasticity. It literally makes your blood vessels more flexible and responsive, which directly addresses one of the primary mechanisms behind rising blood pressure in aging. Exercise also improves insulin sensitivity, reduces inflammation, supports healthy weight, and improves sleep quality, all of which have independent positive effects on blood pressure. 30 minutes of moderate aerobic activity on 5 or more days per week is the evidence-based recommendation, and even breaking that into 3 10-minute segments throughout the day produces meaningful benefits. The fourth strategy that deserves more attention than it typically receives is stress management and sleep. Chronic psychological stress activates the sympathetic nervous system and the hypothalamic pituitary adrenal axis, essentially your body's alarm systems, and sustained activation of these systems raises blood pressure directly through hormonal and neurological mechanisms. Poor sleep does exactly the same thing. Studies have shown that consistently sleeping fewer than 6 hours per night raises the risk of developing hypertension by more than 20%. Practices that genuinely reduce the physiological stress response, deep breathing exercises, gentle yoga, mindfulness meditation, tai chi, spending time in nature, maintaining strong social connections, all have documented positive effects on blood pressure. They are not alternative medicine. They are evidence-based interventions that work through measurable biological mechanisms, and they belong in any serious blood pressure management strategy. The fifth lifestyle strategy is alcohol moderation. Alcohol, particularly in the amounts that many older adults consider moderate, has a direct dose-dependent effect on blood pressure. Consuming more than 1 to 2 drinks per day consistently raises systolic blood pressure and blunts the effectiveness of blood pressure medications. For older adults who are struggling to get their blood pressure under control despite medication, evaluating and reducing alcohol intake is one of the first conversations that should happen, and often one of the most productive ones. When medication makes sense, and when to ask questions. Blood pressure medication, used appropriately and at the right dose in the right patient, is genuinely life-saving. There is no question about this. For older adults with sustained systolic blood pressure above 150, particularly those with additional cardiovascular risk factors like diabetes, a history of heart attack or stroke, or significant kidney disease, medication is generally indicated, and the benefits are well established in the evidence. The risk reduction for stroke, heart attack, and heart failure that comes from effectively treating high blood pressure in these patients is substantial and real. But the conversation about blood pressure medication should not be a one-way street, where the doctor announces a number, prescribes a pill, and the patient simply complies without understanding what they are taking, why they are taking it, what the target is, and what the plan is for monitoring both effectiveness and side effects. You have every right to ask your doctor what target blood pressure they are aiming for and why. You have every right to ask what side effects to watch for and when to report them. You have every right to ask whether lifestyle changes could achieve a meaningful portion of the blood pressure reduction that medication is intended to provide. And you have every right to ask, if you are over 75 or 80 and are on multiple blood pressure medications, whether all of them are still necessary, and whether any of them might be contributing to symptoms like dizziness, fatigue, or cognitive fogginess. Medication reconciliation. The careful review of all medications an older adult is taking to identify those that are no longer necessary, duplicative, or causing more harm than benefit is one of the most valuable services in geriatric medicine. Many older adults are on blood pressure medications that were appropriate at 60, but that, at 78, are pushing their pressure lower than their aging cardiovascular system can comfortably sustain. A thoughtful, informed conversation with your doctor, armed with the knowledge you now have, could genuinely improve both your safety and your quality of life. So let's bring everything we have covered today to a clear, practical summary. Blood pressure management in older adults is not about hitting a single universal number. It is about finding the right number for your body, your age, your health history, and your life. For adults in their 60s, a systolic around 125 to 135 is generally a good target. For adults in their 70s, 130 to 140 is appropriate for most people. For adults over 80, 140 to 150 is a reasonable and evidence-supported range for the majority of patients. High blood pressure that is left unmanaged causes devastating damage to the heart, brain, and kidneys over time. But blood pressure that is pushed too low in older adults carries its own serious risks: falls, cognitive decline, kidney injury, and reduced quality of life. That must be weighed with equal seriousness. The lifestyle strategies that move the needle most powerfully are reducing dietary sodium, following the DASH dietary pattern, engaging in consistent moderate aerobic exercise, managing stress and prioritizing sleep, and keeping alcohol consumption genuinely low. And when medication is part of the picture, it should be the right medication at the right dose, with a clearly defined target and regular monitoring, chosen in partnership between you and a doctor who knows your full health picture. Here is your action step for today. The next time you have a blood pressure reading, whether at home, at a pharmacy, or at your doctor's office, I want you to write down both numbers and bring them to your next appointment. Ask your doctor what they consider your personal blood pressure target to be, and ask them why that specific number is right for you. That one question, "What is my personal target and why?" opens a conversation that could be genuinely life-changing. You deserve an answer that is about you, not just about a guideline. If this video gave you something valuable today, please hit the like button right now. It takes 1 second and helps so many other older adults find this information when they need it most. Leave a comment below and tell me what your current blood pressure reading is and whether your doctor has ever explained what target is right for your age and health. I read every single comment, and I want to know your story. Share this video with someone you love who is managing blood pressure after 50, because this is information that could protect their heart, their brain, and their independence. And subscribe to this channel if you have not already. We are here every week with the real, thorough, science-backed information that helps you live your strongest life after 50. I'm Dr. Michael Kent. Take good care of your heart. And I will see you in the next video.